if you didn't actually get into medical school, the degree itself might not have been the most useful. And I think people started recognizing that after their second year. And so we had a bit of a high dropout rate in the program itself. And I think by the end of it, there wasn't too many, like they accepted 100 people into the program. And I think by the end of it, there was only like 20% of us left or something.
Hi, everyone, and welcome back to STEMPOWER, the podcast where we interview top researchers and doctors in all fields of STEM. My name's Sid.
And my name is Valerie.
In today's episode, Valerie and I will be interviewing Dr. George Phillip, who's an expert in anesthetics.
We'd like to thank you so much for the opportunity to speak with you today.
Absolutely, no problem at all. Thanks for having me.
So, Dr. Phillip, would you like to introduce yourself to our listeners? What is it that you do?
So, I'm an anesthesiologist. So most people would probably know that as the person that puts you out to sleep for during surgery. Mm-hmm. But I mean, it's kind of a little bit obviously more than that. We're kind of the people that monitor all your vitals and kind of make sure you do well throughout the whole procedure. And we also, play a pretty important role in other areas of the hospital too, with respect to pain management, sometimes ICU, intensive care, and chronic pain as well. So there's kind of lots of different facets to anesthesiology in general.
I always thought the anesthesiologists, they would come in at the start of a procedure and then they would just leave immediately afterwards. But you actually stay for the duration to actually monitor their vitals and whatnot?
Yeah, so it kind of depends on the system you're in. Like in America, they do have like a nurse anesthesia program there, and so sometimes there they have like one anesthesiologist dedicated to kind of 4 or 5 different rooms, and so the anesthesiologist will in fact come in for the start of the case, and then once the case is going and for lack of a better term, things are sort of on autopilot. The anesthesiologist might leave the room, leaving the patient under the care of the nurse anesthetist, mm-hmm. and go and start another case in another room, that sort of thing. So it is possible for that kind of model to happen. But in Canada, we have a 1-to-1 model here. So generally speaking with us, we're going to be there for the whole case.
Mm-hmm. Mm-hmm. Okay. So why exactly did you choose to study anesthesiology?
Well, I mean, once you get into medical school, you start kind of trying out different specialties and fields. And this was the one that basically fit the best for me. Mm-hmm. I kind of, early on in medicine, I kind of figured out that I preferred acute medicine versus chronic medicine. Okay. So chronic being more like you have a roster of patients. So this would be like family medicine or internal medicine, where you're seeing patients on a kind of regular basis, following up with them, that sort of thing. Mm-hmm. Whereas acute medicine or something like emergency, like ER doctors, for instance, might just see a patient just the one time and they might never see them again ever. Mm-hmm. So anesthesia is more like that, where, the first and last time you meet someone might be on the same day. So I tended to like acute medicine more than chronic. And I like the skill set that anesthesia offered. It's very like procedure based. You're doing a lot of work with your hands. Not as far as let's say a surgeon, for example, where from start to finish they're using their hands. But ours is just kind of like a mix of procedures here and there. Mm-hmm. So I kept things interesting like that, and also provides you like I said, we're generally using our procedures for surgical procedures, but it's actually very useful for the hospital in other situations as well. Like you'll get called to a lot of emergencies to help intubate people, or if they can't get access, try and start an IV. For obstetrics, we get called a lot for epidurals, for pain management, that sort of thing. So it's an interesting skill set to have, mm-hmm. Where you're kind of a useful person to multiple different departments in the hospital. And in general, I just liked the OR environment. It can be hectic, but in general, it can be a little bit more relaxed as well. Uh-huh. And you can sometimes we have music playing in the background. You can get some conversation going with your colleagues, and and you get to wear scrubs, which is basically like wearing pajamas all day. So it is kind of nice for other reasons.
Yeah, well, it sounds like you're, juggling quite a bit around the hospital. Like you're needed in this area and then you're needed in another area. So it seems like maybe you would need like a lot of majors or degrees to sort of help you in the anesthetics department. So what exactly is your educational background?
Yeah, I don't have too many degrees. Like, I mean, I guess it's pretty average for like a doctor. I went to high school and then got an undergraduate degree at Ottawa U in biomedical science, which is a pretty interesting degree, which I'm pretty sure they don't offer anymore.
Wow.
Yeah. It was, I mean, I remember starting and like it was kind of seen as like a pre-med kind of major. But the idea was, at the time, like, and it still is, that the medical schools were interested in getting well-rounded candidates as opposed to just kind of purely science-based candidates. And so like what the program aimed to do is try and make you more well-rounded. And so it offered you a lot of, it didn't actually delve too much into science itself. So like first and second year courses pretty much maxed out is like how much science you did. So I never took any kind of third year biology, chemistry, those kind of courses. It was really after second year that was kind of all the specialization into science they kind of required, and there's a lot of electives that you can do. So I ended up taking sociology classes, law, a lot of I took an English writing class, linguistics, business, and so it kind of made you well-rounded. But I guess, and this was the first year that they actually offered that program. And one of the, I guess, unintended consequences was that it did just that, and it made you well-rounded, but didn't really give you enough specialization into one field to be able to, I mean, I don't think I qualified to do any masters or anything. I think there's one master's in like health science or something that if I took like an extra 2 or 3 courses, then I would qualify for. And so if you didn't actually get into medical school, the degree itself might not have been the most useful. And I think people started recognizing that after their first, second year. And so we had a bit of a high dropout rate in the program itself. And I think by the end of it, there wasn't too many, like they accepted 100 people into the program. And I think by the end of it, there was only like 20% of us left or something. Like the grand majority of people had actually transferred out of the program. And not like a crazy like switch, they switched from biomedical science into like biopharmaceutical science or biology or something like kind of similar. But I think it was more like because if you didn't get into medicine, then you would have to, like I said, take extra courses, that sort of thing, before you qualify to be able to continue on doing masters and stuff. So luckily I got into medical school.
Right.
I was one of the few people that actually completed the program. But yeah, it worked out for me. So then I finished up at Ottawa U and I started medical school at McMaster, where they had the shortened program for 3 years as opposed to 4. And so I did that, finished that off, and then I did my residency in anesthesia in Halifax, actually at Dalhousie. So spent 5 years there doing my training, and then I did 1 extra year of what's called a fellowship after your residency. So it was just a little extra kind of specialization into echocardiography, which is basically ultrasounding of the heart, and in more of like a perioperative context. So yeah, and then after that, I thought that was enough school, so I just started working after that.
So just out of curiosity, how many years of medical training did you receive, including your undergraduate and medical school, before you actually entered the workforce?
Well, I guess like overall, like if I count my fellowship and my residency as well, that would be 13 years.
Wow. Okay.
Wow. 13.
That's a long time.
Yeah, but I mean, once you enter residency, you basically it's a paying job, so you're kind of mixing in school with work. So yeah, like I was making a salary starting in my first year residency, and so it's kind of like a mix between you're kind of learning on the go kind of job. So yeah, so like I was kind of entered the workforce, I guess after 7 years, but the training kind of continued for another 6 years basically.
Right. Okay.
Wow. And do you think that having an undergraduate, like as a pre-med undergrad, did that help you at all in getting into medical school?
I think, yeah, overall it does. Not specifically for the medical school that I went to. So McMaster is kind of known for not requiring as many kind of science-based courses as some other schools. So, you know, actually technically to get a McMaster, you don't need like any science courses at all, I'm pretty sure. Like we had people who had majors in, you know, English and arts and that sort of thing in the medical program at McMaster specifically. But if you're applying to other schools like, you know, U of T and Western, that sort of thing, they're more kind of traditional and still require a lot of the science-based courses as prerequisites. And so like, I mean, it's basically what it does. It just kind of gives you all the courses you need that would kind of fulfill all the requirements for the different universities.
Yeah.
So yeah, I mean, in a way it does prepare you, but I wouldn't call it like an absolute necessity.
All right.
Okay, so moving on. When did you kind of know that medicine was the industry or field that you wanted to pursue? Like, when did it kind of click? Like, what age, or was there a reason why you went into medicine?
Yeah, it's sort of, I mean, it started kind of late in high school when, you know, you have to start taking that sort of stuff seriously a little bit more, and, you know, you got to choose career paths, that sort of thing. So I think, if I remember correctly, I was considering 3 different things: law, accounting, and medicine. So at the time I just kind of just sat down and talked, I guess, with a few people from each of those fields. Just to see, you know, what it was like, just to get a little bit more insight into the specialties. And what I kind of started noticing was that nothing to do with the actual kind of content itself. I just really appreciated a lot of the doctors that I was talking to as kind of thoughtful people, helpful people. They're nurturing, they're very kind, easy to talk to. And so I was just like, I think that's the kind of person I want to be, as opposed to not necessarily picking it based on the content, but I just kind of liked or admired the people that I was talking to. And so that played a big role in terms of choosing medicine specifically from those 3 for me. But yeah, I guess late in high school is when that really started.
I think that's actually very relevant to Sid and I especially, and to some of our listeners as well, because we are in high school right now, and it's that time for us to choose sort of what we're interested in. And I think for both of us, it's also something medically related. So to get more technical in the questions, what are the types of anesthesia?
So, I mean, probably the most popular kind that most people are think of when you think of anesthesia, it's general anesthesia. So that'd be kind of like going off to sleep for a procedure. But there's been a trend for, you know, past few decades actually of moving away from general anesthesia and moving on to more kind of regional techniques. You'll see a lot of neuraxial anesthesia, which is spinals or epidurals, which is basically freezing up nerves along the spinal canal so that people don't feel anything throughout the procedure itself. But you can actually stay awake through it if you'd like. Some people don't like that as well, so we usually mix it in with a little bit of sedation or something. But yeah, so, and you can also do nerve blocks as well, so specifically kind of numbing or blocking the limb that they're operating on through basically injecting freezing or local anesthetic into like a nerve bundle basically that serves that limb. And again, that way you kind of completely numb that area up while the person can remain completely conscious if they like. Yeah, and then finally there's also local anesthesia too, which is just straight up putting a little bit of freezing. I mean, this is more for kind of like smaller minor procedures where if you're just making a small incision in, you can just put a little bit of freezing and just numb that specific area up and then proceed after that.
Okay, so you've mentioned needles, but what are some of the other ways that anesthesia is administered to a patient?
Yeah, so generally speaking, it's mostly done through either an IV, and I would say the grand majority is through an IV, and then also through, if we do have the patient intubated, then we can deliver anesthetics through that modality as well. So, but generally speaking, it's mostly done through intravenous, which I guess is sort of a needle to get the IV in place. But once we have that that plastic. It's getting louder, I think.
Just a little bit.
Sorry. Yeah. But yeah, once you have the IV and you can give most medications through there to get people off to sleep.
All right. So, what are some risks that patients should be aware of, when going, under anesthetics?
Yeah. So like usually what I tell people is that nausea, vomiting is probably the most common side effect or risk that you're going to see. It's around 30% or so, but we give a lot of medications while they're asleep to try and minimize that. We kind of preemptively treat them with anti-nausea medications, so we can usually bring the rates down to under 5%, which is pretty good. Dental damage and a sore throat is possible too if you are intubating patients, and that's basically just putting in a breathing tube to help with their ventilation throughout the procedure. So we always quote that risk as well. Then you get into kind of more serious stuff, but at the same time, pretty rare things. So you can always have an allergic reaction to any sort of medication that we give to people. They're pretty rare. I, for instance, have never had a serious kind of anaphylactic reaction happen. But a lot of the medications that we use can be pretty dangerous, especially if you're not the healthiest of persons. So you can have kind of complete cardiovascular collapse, respiratory depression, heart attacks, strokes. I mean, death. We always say these things, but they're exceedingly rare. Anesthesia has actually made some pretty great strides over the last few decades into becoming a very safe specialty overall to be a part of. And so, yeah, overall, I'd say they're pretty minimal. But when they do, if one of the rare ones do occur, it can be pretty serious. So it shouldn't be taken lightly, but luckily they are pretty rare. And one of the things actually that we are seeing a little bit more now, it's kind of still emerging, is cognitive impairment. And we are seeing that a little bit more in the elderly population, where once you get past the age of 70, 80, 90, if you're getting long general anesthetics specifically, you can see like a permanent cognitive decline happen afterwards. So a little bit more trouble with memory or cognition, that sort of thing afterwards. So I mean, that's still an emerging kind of data and science. And so, but you are seeing a movement away from general anesthetics, I would say, over the past few decades, and that is one of the reasons.
So just out of curiosity, do anesthesiologists need to have a proficiency in pharmaceuticals in their job? Like, do you need to know about different types of pills maybe? Is that part of your job?
Yeah, I mean, most doctors kind of have a pretty good kind of sorry, that's just my phone. I'll turn that off. A pretty good appreciation for pharmaceuticals in general. Like I would say in anesthesia, we definitely do a lot of like calculations. So kind of pharmacokinetics and dynamics on the go, and dosing, because we dose a lot of our medications by weight. And so, I mean, there is a slight amount of math involved for each patient, and figuring out max doses, minimum doses, effective doses, that sort of thing. So, and that's actually one of the reasons why I liked anesthesia too. I guess I forgot to mention before, is that there is a decent amount of quick kind of mental math that you kind of you do on a daily basis. And so, yeah, I mean, but I wouldn't say it applies to all of all medications, because we have a very kind of select few medications that we stick to in anesthesia. But for those ones, yeah, there's some math involved for sure.
Okay.
Yeah, absolutely. That makes a lot of sense. So, in general, what would you say are the most common ethical issues or dilemmas that an anesthesiologist might face?
So yeah, ethics wise, I mean, I think the one you're probably going to see the most is obtaining consent and trying to assess someone's capacity and whether they're able to, give consent. And so, we run into a lot of people during not the best time in their lives, right? And they might be, whether it's under the influence of a drug or not in the right frame of mind because of the actual illness that they're experiencing that they need the surgery for. And so a lot of the time that we're not just speaking with the patient themselves, we're speaking with their families or their representatives, um, their wives, their POAs, that sort of thing. There, that I would say that's probably the most ethical kind of concern that we run into. It's just that, and also I'd say protecting a vulnerable population. And so, I mean, you have these people who are entrusting their lives with you, and they're very extremely vulnerable when they're under anesthetic. And so, I think protecting them, their decency, that sort of thing, and still treating them with respect while they're under the influence of anesthetics is probably the other one. In terms of dilemmas on a daily basis, probably the one that you're going to run into the most as an anesthesiologist is that decision of weighing the risks and benefits of proceeding with the surgery or delaying the surgery.
Right, because you never know what's going to happen. Yeah.
Yeah, exactly. And so, some people will show up in what we call a not optimized form, where there might be some other medical concerns that they have, which needs attention as well. And you're trying to balance, what should get done first. Should we send this person off for this test, or but they are having this kind of acute need right now, and it might be in their best interest to take care of that first before we send them off for that test. So trying to make those decisions about balancing the risks and benefits of going either route basically would probably be one of the tougher parts of the job, I'd say, for sure.
Awesome. So moving on, do you ever use your skills as a doctor in your day-to-day life?
Yeah, I would say, I mean, it's hard not to almost, right? Because, I mean, in general, people ask you for advice, a little medical kind of tipper question here and there.
Of course.
That kind of goes along with it. But I mean, I think the more interesting part for me is they do definitely instill like a certain, I'd say, mindset or way of thinking. And you can't really just turn that off like when you go home. And even if you're not dealing with medical issues per se, you might be still applying that same type of thinking. So, if you run into a problem, we're always taught as doctors to come up with a differential. And so you have to really not just come up with one reason why something might be happening, but try and, think outside the box a little bit and try and think of, as many possibilities that you can that could, potentially explain this problem. And, whether you still kind of use that way of thinking when you're attacking a problem outside of medicine, or even, we're taught as doctors to really be conservative with, ordering medical tests, that sort of thing. And, if you are going to order a test, make sure that it's for a reason, and it's going to change your management, that sort of thing. So I might be, standing in Home Depot and be like, oh, maybe I should check on drive by another store to see if it's like a lower price or something. And you're like, well, is this going to, really change your management, George? I mean, you're still going to need this and you're going to buy this anyway. So, I mean, what's the point? And you kind of apply that kind of thinking like in a different way, of course. Mm-hmm. But you can't really just turn that off. And so for sure, like even especially in anesthesia, like one of our responsibilities is trying to basically foresee problems and issues before they even arise and trying to address it. And so I definitely have that mindset, like, and my friends kind of notice it too. Like, even if we're just like, we're talking about going to dinner or something, I'm like, okay, and how are we going to get home, and how are we going to do this? And how, like, you're planning like 5 steps ahead of time. They're just like, geez, man, like, we haven't got to dinner yet. I'm just like, oh, I'm sorry. I'm kind of trained to think that way, right? You kind of try and cut off the problems before they even happen. And so, yeah, no, I definitely kind of, those skills kind of, I don't know if they call them, my friends wouldn't call them skills, they'd call them more annoyances, I guess, but they definitely kind of permeate through the rest of your life too.
And finally, what are some tips that you could give for those in high school, such as Sid and I, that are looking to pursue a career in medicine?
Yeah, so I mean, I think it kind of goes without saying that you have to be kind of successful academically, get good grades. But I mean, outside of, and I think that's, you know, common knowledge, people probably already know that. But I would say probably the one thing that would really help you, or medical schools really like to see, is someone who knows how to manage their time effectively and is well-rounded. And so not just having good grades, but also managing that while, you know, having a lot of kind of extracurricular activities, to show that, you know, you're not just spending all your time studying and that's how you end up with good grades. I mean, if you're showing that you can do competitive sports and that you can, you know, volunteer at, it doesn't really matter what you volunteer at, but if you can spend other time doing other things, but also at the same time be successful academically and manage your time effectively, I think that shows the medical schools that you're able to do that, which I think is what they're looking for. And yeah, they really like seeing kind of success outside of the classroom too. I mean, one of my friends who got into medicine, he was an Olympic athlete, and so yeah, he would spend, you know, like, to become an Olympic athlete, you know, you got to do an incredible amount of training and stuff. So if he was training like 4 or 5 hours a day after school, you know, doing his sport, and then, but also at the same time managing, you know, getting good grades and stuff. And so he didn't have a lot of kind of volunteer activities or anything, because, you know, he was dedicating his entire life to outside school, to becoming, you know, an Olympic athlete, which is not easy to do. And so, but, you know, because of that, you can kind of show that, wow, you're not just having success in the classroom, but also managing stuff outside of the classroom and having success at that as well. So, I mean, my advice is, yeah, you gotta show them that you're able to manage your time effectively, kind of juggle multiple balls. And I wouldn't say, like, a lot of people ask, you know, should I be volunteering in a hospital specifically, or you know, what specific kind of volunteer or, you know, extracurricular activities they should be doing. And I wouldn't say they need anything specific, but I would just kind of trust your strengths, your interest, and whatever you think you can be the most successful at, choose those, because I think that's what is really important, is, you know, whether that's, it doesn't have to be, you know, traveling off to some country to build a house or something there. I mean, if you, like I said, this guy, my friend who decided to become an Olympic athlete, basically, that shows an incredible amount of dedication, hard work, all those kind of things that really comes through there. So yeah, that would basically be it. Try and make sure you have a healthy kind of life outside of school, and yeah, show success in that.
Yeah, that makes a lot of sense. All right.
Kind of like what you guys are doing. I mean, I heard you guys have over 6,000 listeners now for this podcast.
Yeah.
It's pretty crazy. Yeah.
It's been, steady. It's slow growth, but it's definitely there. It's been good. I think we've come a long way from our earlier episodes. So it's been great. Yeah. So thank you so much, Dr. Philip. Unfortunately, we are out of time. Val and I would like to thank you once again so much for taking the time out of your day to speak with us.
Yeah, absolutely. It was, thanks for having me. It was a lot of fun. Yeah, I think it's great what you guys are doing for the listeners and other kids out there. So keep up the good work.
And thank you all once again for listening to this episode of STEMPOWER with anesthesiologist Dr. George Philip. Be sure to check us out on all our social media platforms at STEMPOWER Ottawa. We hope you stay tuned for the next one. See you next time.